people we are known to each other. Most of the people we are known to each other. But if someone, then I'm trained by Dr. Zia and Dr. Sufi from Khan and working with Dr. Fahad currently on some short fellowship. So Dr. Zia has assigned me task to means present something the on this case. So this is the case of a 60-year male with left leg venous ulcer, non-healing for last 5 years. He has a history of DVT for 10 years, means 10 years back, and there is left iliac vein stenosis on imaging. So anyone of the participants, what first thing that comes in mind when reading this scenario? Anyone?
So it's a post-thrombotic syndrome?
Yes, post.
Yeah, this looks post-thrombotic syndrome because history of DVT, non-healing venous ulcer for last 5 years, and in the picture you see the, although I have taken the picture not from the patient but from the internet. So the first thing that comes is post-thrombotic syndrome. Any other thing? Anything that comes in mind with left leg, left iliac vein stenosis, or left leg DVT, or
Compression of the left iliac vein
yeah,
Yes.
left
by
iliac
the
vein
right iliac
compression.
artery.
Yeah.
syndrome. पिक्चर राइट की है, लेफ्ट की नहीं है.
हाँ सर, पिक्चर तो मैंने आपको बताया कि मैंने ये इंटरनेट से उठाई हुई है.
मेरे सर ने लेफ्ट साइड की अगर मोस्ट कॉमन है तो मेरे सर ने हो सकता
Method, yeah. But we can't say that May Turner is exclusively to the left side. There are case reports where there is compression of iliac veins on right side also, and there are case reports where there is compression of external iliac veins also. So there are compressions most commonly between the right common iliac artery and vertebra, right common iliac and artery and vertebra, but there are compressions that can occur on right side and can occur over the external iliac veins also. The second thing, what clinical findings do we expect in these patients? So patient with history of DVT, patient with non-healing venous ulcer, and iliac stenosis, what things can we see on clinical examination? Anyone?
Yeah,
On
everyone
clinic-
has to type in the chat box what question are asked. Everyone has to write the chat in the chat.
So clinical signs of advanced severe chronic venous insufficiency, including leg edema, lipodermatosclerosis, non-healing ulcer, phlebo lymphedema, secondary varicose veins, and suprapubic varices, and sometimes varices over the anti-abdominal wall going high up depending on the level of obstruction. So these all findings we can expect in this patient. Clinical evaluation. So one thing that we have to look inside the box and out of the box. So if you see the patient's age is 60 years. So not only the venous thing is obviously the major thing, but we have also to look for the other causes such as peripheral arterial disease. In every patient with non-healing venous ulcer, we have to look for peripheral arterial disease also, and to make sure that blood supply to the leg is adequate. And sometimes the other causes like vasculitis are also the contributing factors. So clinical evaluation of the not only the venous system, but to rule out the other causes. Just a question from all of you, especially the fellow. Should we offer varicose vein surgery to a patient with ipsilateral leg DVT? So this is the patient who has history of left leg DVT 10 years back. Now he has varices over left leg. Should we treat the varicose vein or not?
Yes, depending if there is reflux at the junctions, so varicose veins should be treated, and also the perforator. There, if there is a perforator incompetence, so perforator incompetence should also be treated before going towards the abdominal vessels.
Okay, we can discuss further. This thing we will discuss in the coming slides, I think so. So as we discussed, this is the post-thrombotic syndrome, most probably the consequence of post-thrombotic syndrome. So the pathophysiology of post-thrombotic syndrome, anyone of the fellow participants, Mukim, Kamran, what is the pathophysiology of post-thrombotic syndrome? So basically, the pathophysiology of post-thrombotic syndrome lies in two factors. One is the obstruction and other is the inflammation. So whenever there is the thrombosis of veins, especially the iliofemoral venous segment, then there is fibrosis and recanalization. But the recanalization is always partial with the development of synecdoche, and there is outflow obstruction there. So one part is obstruction. The other is inflammation. Inflammation leads to two things. One is the loss of vein valves that leads to reflux, and other thing is loss of vein wall compliance. So with inflammation, there is loss of vein wall compliance, and the compliance of vein wall is lost. So obstruction, reflux, and loss of vein wall compliance. These three things. The third thing, that is vein wall compliance, is most important with respect to the recent, means the trials for chronic DVT like attract. Many people say that the patients who underwent thrombolysis on day 14, so there is already the onset of inflammation. And although the obstructive factor is restored, so there is no obstruction, but inflammation is induced. So now the vein wall valvalized and the vein wall compliance is lost. So that's why even in the ATTRACT trial, there are the results in prevention of post-thrombotic syndrome are not as good as expected with the early thrombus removal with pharmacomechanical thrombolysis. And when they have compared the two subgroups in the ATTRACT trial, those who underwent thrombolysis on 4th to 8th day had better outcomes in terms of PTS as compared to those patients who underwent thrombolysis after day 8 to day 14. So vessel wall compliance is also a major factor. So outflow obstruction and reflux due to the damage to valve, and vessel wall inflammation and loss of vein compliance due to damage to vein wall. So this is the pathophysiology of the post-thrombotic syndrome. To assess severity, so roughly it is about 50% of the patients who have experienced DVT. So they develop mild, moderate, or severe PTS. So about 5 to 10% of the patients develop severe PTS, but total 50% of the patients do develop some degree of post-thrombotic syndrome, and it needs to be assessed. And the interventions, treatments are all offered based on the severity of post-thrombotic syndrome. So there are many scoring systems that categorize the post-thrombotic syndrome, but the most widely used is the Villalta scoring system that is even endorsed by ESVS and the American Venous Forum and major AHA. So this is the most commonly used both in the clinical practices and in the research purposes, and it includes both the symptoms as well as the signs. And Villalta is, so less than, if the Villalta score is less than 5, then we don't label it as post-thrombotic syndrome. If it is 5 to 9, then it is mild. 10 to 14, it is moderate, and severe if 15 or more than 15. Any patient who is having post-venous ulcer due to post-thrombotic syndrome is having severe. So it is categorized as, means it severe post-thrombotic syndrome. Coming to the management option of patient with PTS. So the management options, what options do we have for patient with PTS? So compression therapy. Compression therapy may be compression stockings, compression bandage, intermittent pneumatic compression pumps, or some physician or means modified according to the patient stockings. Then exercise therapy, moderate degree of exercise therapy is recommended for these patients. Then comes to venoactive drugs. There is evidence in the literature regarding venoactive drugs and the response of drugs to the different signs and symptoms of the PTS. So some drugs are more helpful in relieving edema. Some drugs are more helpful in relieving the claudication, and sometimes some drugs are more helpful in helping the ulcer to heal. But there is no level 1 evidence, and many of the guidelines don't recommend. In ACCP guidelines recommended in I think 2008 with the usage of venoactive drugs, and then in 2012 they are retracted back the drugs. But many societies still recommend the concomitant use of venoactive drugs along with compression therapy, exercise therapy, and intervention if possible. Coming to the intervention for any patient with PTF, so the options are open surgery and endovenous. Endovenous is the recommended and first choice. So for deep systems, iliac vein stenting, and for the superficial ablation, perforator ablation, and sclerotherapy, all are the options. And for the open options that we have are bypass surgery, and for deep reflux, we have valve replacement therapy or valve reconstruction. So these are the options that we have total for this one. Coming to the indications for intervention. So when we are going to offer intervention in a patient who has PTS. So obviously the patient who has PTS, so he is having some degree of stenosis in different segments of deep veins. He might be having reflux in the deep veins. He might be having reflux in the superficial veins, but there is no role for prophylactic treatment of silent lesions. So the algorithm is a patient with PTS are to be managed with compression therapy, stockings. But if a patient is having means there is no role that we offer. We have seen the iliac lesion and we offer stenting to prevent the development of ulcer. So no role of prophylactic therapy. Any patient with C3 to C6 disease with failure to conservative therapy and persistent symptoms. Venous claudication, venous hypertension syndrome, and atypical leg syndromes causing the lifestyle limitation not seen mostly in our population. हमारे यहाँ इतना भागते दौड़ते नहीं है, लेकिन अगर आप यूरोपियन कंट्रीज में जाते हैं, हर कोई आता है कि मैं जॉगिंग करता हूँ, आई कांट वॉक नाउ, आई कांट run now, I need help. So venous claudication is most of the times the indication for offering intervention to them as compared to the ulcers. But here in our country, we have more patients of venous ulcers as compared to the venous claudication, and the most common indication in our setups is venous ulcer as compared to venous claudication. एंड उसके बहुत सारे रीजन हैं कि हम पेशेंट को डीवीटी हो गई, अब पेशेंट को हमने स्टॉकिंग एडवाइस कर दी, पेशेंट ने स्टॉकिंग से यूज नहीं की, पेशेंट के पास पैसे भी नहीं है कि स्टॉकिंग यूज कर सके, डिफरेंट रीजन व्हाटसोएवर, स्टॉकिंग अवेलेबल ही नहीं. Then geriatric patients who cannot self-apply compression due to arthritis or frailty, recurrent cellulitis of limbs secondary to obstructive lesions, acute iliac vein thrombosis caused by an underlying stenosis, and phlebolymphedema. These all come in the indication for intervention for the patients with post-thrombotic syndrome. So although the patient, we have assessed patient clinically, the patient's history, patient clinical examination, the patient has PTS. From history and examination, then patient, we have assessed for him, so he has ulcer. Ulcer means severe Villalta score more than 15, and he has clear-cut indication for offering intervention. So now what is the first step? The first step is the ultrasound scan. Ultrasound scan can help. Ultrasound scan is mandatory thing for every vascular surgeon, I think, and everyone who is offering, especially the persons who are offering venous interventions, either superficial or deep. So this is the first test of choice to identify venous disease. Ultrasound, on ultrasound duplex, we can see indirect findings of PTS. So indirect findings means there is outflow occlusion in the iliac vein. So iliac vein is occluded. Then we can see on the common femoral vein the loss of physicity of flow in the distal veins, because if the veins are occluded, then obviously there will be no transmission of respiratory pressure, and the venous flow will be monophasic and no respiratory phasic variation will be obtained. And same goes for the poor response to augmentation. If we are augmenting, blood is not going high up, so there will be no augmentation. So these are the indirect findings. Direct findings are slightly difficult to see with the normal machines, but most of the good ultrasound machines and some skills we can see the direct findings of. So the most common finding is absent flow in the iliac veins. Iliac veins are having spontaneous flow when we examine the pelvic veins. But if there is DVT or CTO of the iliac veins, then we'll see no flow or only trickle flow in the iliac veins. And the most important thing is internal iliac vein flow reversal. This is common in the patients with May-Turner syndrome. So if there is any type of stenosis or compression in the common iliac vein, it is said that it is an illusory finding. So any patient who is lying flat and we are doing ultrasound or we are doing any cross-sectional imaging like CT venogram, MR venogram, so obviously the artery will lie over the vein and we'll see a compression over the vein. And it is, people have, means there are many research articles, so they have seen that if we examine all the CTVs and MRVs, we will see about 70% of the iliac vein lesions. So how can we know that this lesion is significant enough? So then there are maneuvers, means the patient is lying flat. So ultrasound has the advantage that we can do the same examination in the semi means supine position. So there are tables that can go in semi-supine position, or even we can do the scan in the standing position. So if there was compression when patient was lying down, but if the compression goes away when the patient is standing or in semi-supine position, that it means it was due to the gravitational effect, illusory effect, but it is not the true effect. The second the important thing that rules out the means that differentiate between the significant stenosis versus this non-specific compression due to gravity is the reversal of flow in the internal iliac vein. So in the internal iliac vein, the routine flow is from pelvis to pelvis uphill, but with the iliac vein compression, the flow will be downward. Same goes for the pelvic collaterals. If the pelvic collaterals can be visualized on cross-sectional imaging or on the ultrasound scan, then it means there is some type of stenosis are being. And then we can visualize the external extrinsic compression, assessment of superficial system, because it's not only the deep system, but we have to assess the superficial system along with the deep system. So we can assess for the superficial reflux, whether it is reflux in GSV, short stiffness vein, perforators, or there's no reflux. And then the most important thing is the common femoral vein confluence. So if whether common femoral vein is free of disease or not, so we can visualize that, okay, there is stenosis or compression of the left common iliac vein, the left common and external iliac veins cannot be seen, but the common femoral vein is okay. Sometimes we see that common femoral vein is also diseased, and the femoral vein and profunda veins both are diseased. Our femoral vein is diseased, but the profunda vein is patent and profunda vein is draining into. So we can assess the common femoral vein confluence, and then deep femoral, profunda, and profunda, popliteal, and femoral vein all can be assessed on ultrasound. So ultrasound is the most important investigation in the venous diseases. So here we can see the external compression. So this is the right common iliac artery. This is left common iliac artery. This is the vertebra, and this is the left common iliac vein that is being compressed between right common iliac artery and the vertebra. Here, this is again same. So this is the right common iliac artery, and this is the left common iliac vein that is being compressed. So can be visualized with good machines. This is the indirect finding. So you see when we compare between so if, for example, this is the normal leg, this is the phasic variation with the respiration. But here there is uphill occlusion in the iliac vein. So in the common femoral vein, you see only the monophasic flow. There is no phasic variation. This is indirect means indicator of something, some stenosis or some occlusion high up in the iliac veins. Oh, this is the external iliac artery, and this is the external iliac and common iliac veins, and this is the internal iliac vein. So you see the direction of flow in the external iliac vein is uphill, but there is a retrograde flow in the left internal iliac vein. So this signifies that there is compression of the external common iliac vein. If there is compression, but there is no reversal of flow in the internal iliac vein, then we don't consider the iliac vein compression is significant. Coming to the cross-sectional imaging, so CTV and MRV, they are most of the time done when we are planning. So we will discuss this further, but CTV and MRV are only done when we are planning some intervention for a patient. If we are not planning for intervention for for a patient, then we most of the time don't go to order CTV or MRV. And so when ultrasound scan shows suspicion of iliac cable obstruction, or can also, but the advantage of CTV and MRV are that they can also identify the external compression, including tumor, cysts, retroperitoneal fibrosis, and like that. Ascending and descending venography, most of the time, they are only means left for the intervention purpose, not for the diagnostic purpose in these days, because of the high quality ultrasound scans, CT venography, and MR venography. But still, in some cases, when the patient is highly symptomatic and we are suspicious on CTV, MRV, and duplex findings about the May-Turner or some iliac stenosis or some post-thrombotic syndrome, then venography can be offered with or without IVUS. So when there are suspicious findings on cross-sectional imaging, it can evaluate both the obstruction and the reflux. But the main thing is single plane can miss the lesions. So always bidirectional, means AP and lateral, AP and lateral, AP and lateral. So if we see this ultrasound, MR findings, and the CTV findings. So here is the compression of the iliac vein, and then same finding can be seen on this is the vertebra and iliac artery and the compression of the iliac vein, and same goes on for the CT. The MRV, if we compare the CTV and MRV, so MRV is means more sensitive in identifying the disease, especially in identifying the landing zones in whether we can find the disease-free landing zones for the stents. So MRV can identify the landing zones better as compared to CTV. CTV usually sees because of there are many correlators of due to post-thrombotic syndrome, vein lumen is not good. So CTV can not identify the sync inside the post-thrombotic vein, but a special sequence MRV can identify the sync, especially in the common femoral vein confluence. So this is the importance of bidirectional venography. Venography, so here we can see this is AP view. So in AP view, especially in the May-Turner syndrome or compression syndrome, so this is the anterior-posterior compression, so vein diameter is enlarged. When we do the venography, in AP view, the vein looks enlarged and we can't see any imaging. So most of the junior vascular surgeons, or means most of us even, so when we do venogram, it is AP compression, and we are imaging in the AP section. So the vein looks very good and very patent, and we don't see any stenosis. But if the same we rotate in the lateral view, then the stenosis can be visualized. So here are the other means imaging for, so this compression, the fading of the contrast with blockage of the contrast to flow, and the visualization of collaterals, lumbar collaterals, and reflux in the internal iliac veins, and visualization of collaterals with means residual or holding of the contrast in the distal iliac veins, and the fading of the contrast in the common iliac vein. This is the typical finding. So not like arteries, means in arteries we see the typical stenosis like narrowing, but in the common iliac veins we don't see the stenosis like narrowing, but it is like widening. It is called paincaking. So paincaking of the common iliac vein with the presence of collateral. So this is typical of the iliac vein stenosis. So and if we do the image venogram for May-Thurner syndrome, it will look like the broadening of the iliac vein as compared to external iliac vein, and the presence of collaterals. So coming to the venography is not the gold standard, and it has many disadvantages when we are going to evaluate the iliac venous systems. And IVUS is the gold standard in morphological diagnosis of iliac veins. It has many advantages. So iliofemoral venous stenosis missed with venography in 25% of the patient as compared to, and in some studies even the patients. So it is missed in some studies show in up to 47% of the patients it can be missed. And the one what you can say the drawback of or one objection on the ATTRACT trial is also the same thing, that they offered the PMT and then offered selective stent to the patients who were seen in whom the stenosis was seen on venography only. So there are queries that there might be some stenosis that were missed because IVUS was not done, and only the imaging was done with phlebography. So there are chances that many patients who needed stent but they were not stented, and therefore their symptoms did not improve. So this is also one of the things that comes in ATTRACT.
Yeah, Waryam, that is very excellent presentation. Very important point you are mentioning. But for only for the time sake.
So, okay, I'm going on. So in lesions visible with contrast venography, the degree of stenosis is significantly underestimated compared to IVUS. Level of iliac confluence is determined more accurately with IVUS, and upper and lower landing zones are more accurate visualized with IVUS as compared to venography. So IVUS is gold standard as compared to IVUS. Coming to the algorithm for intervention. So the patient with PTS might be having superficial venous reflux, might be having deep venous reflux, might be having the deep venous stenosis or occlusion, or combination of all those. So the algorithm for offering intervention to those patients depends on the location of the disease, whether the lesion or issue is in the superficial system, is whether there is superficial reflux or not, where there is deep reflux or where there is deep obstruction. And same goes, the lesion is located in the femoropopliteal segment or in the iliofemoral segment. So in the femoropopliteal segment, the stent is not recommended, but if there is lesion in the iliofemoral segment, then the stenting can be offered. Severity, so if the iliac, if there is iliac lesion, but if it is stenosis, and versus if there is iliac lesion and it is total occlusion, so the severity of the lesion. And same goes for the superficial reflux. So if there is superficial reflux, but if it is more than only 0.5 seconds, but if there is superficial reflux that is more than 2 seconds, 3 seconds, 4 seconds, then it is more significant, and then it needs to be treated. And then invasiveness and success of the procedure. So obviously the superficial vein ablation is less invasive as compared to venous stenting. So the less invasive procedures are considered first, then the deep venous intervention. So routinely, if any patient with post-thrombotic syndrome having severe are significant major reflux, then superficial veins are treated first, then the stenosis of the iliac veins, and then in the if the patient is not improving with all these interventions, then the deep vein valve reconstruction comes. So this is the algorithm for intervention. Considerations before offering any intervention are especially the iliac vein stenting. So expectations of the patient. Sometimes the patient, we have seen many times patient wants that my color of my legs becomes normal. My ulcer, patient are concerned about venous healing. Patients are concerned about not wearing stockings after the intervention. So we should know about the expectation of the patient. Then inflow. This is the most important thing to look at before offering any iliac vein intervention. If so, inflow means the good inflow is any patient who is having both the femoral vein and profunda vein patent, then it is considered as good inflow. But it is adequate if any of means profunda vein or femoral vein, if any one of them is patent, then still inflow is considered as adequate. But if both the veins are gone, then it is poor inflow. And if it is poor inflow, then it is means a strong factor not to offer any intervention. So if we have done ultrasound duplex properly and we have evaluated inflow in the patient, we have seen that, okay, femoral vein and profunda vein are okay, or at least one of them are good enough, and they are disease free with good flow, then we can think about offering iliac vein intervention, and then we can order CTV or MRV. Otherwise, if the inflow is bad, and then there is no fun of ordering the CTV or MRV or talking to the patient about offering the iliac stenting. Mobility of the patient, so means less mobile patients, morbidly obese patients who are not mobile, they are not good candidates for offering iliac stenting. Same goes for the patients who are either not fit due to some conditions, bleeding disorders for anticoagulation or antiplatelet therapy, or they are not willing for anticoagulation or antiplatelet therapy, or we expect that they'll not be following up properly for the surveillance of the stent, then these patients are also not considered good candidates for offering intervention. Coming to the technical aspects, so anesthesia, all patients with deep venous interventions are done under general anesthesia because the ballooning is very painful. So no local anesthesia. Sometimes if we see that there is focal occlusion, then we can be done under monitored anesthesia care, but no local or regional. Access. So access, most of the time we need access in the femoral vein, not the common femoral vein, because most of the time we have to land in the common femoral vein. We have to take the access from the femoral vein at the adductor canal. It has the advantage of the shorter route. From this route, we can assess the inflow. And it is supine position. So if we are unable to cross from downhill, we can use the neck vein IJV. Sometimes we use the popliteal vein if we can't assess, because if we say that what is the most difficult part of any intervention for PTS, so that is the access, because the limbs are so swollen, edematous, and the vein is sclerosed. Most of the time the thrombosis involves the femoral vein also, so it is sclerosed, small caliber, and most of the time lying behind the artery. It is the difficult most of the difficult part, and sometimes it takes more than 1 hour to just get the access of the iliac vein. Crossing depends on the severity. CTOs means most of the time can be crossed from the integrated approach. Sometimes it needs jugular approach, but they are more venous occlusions are more easy to cross as compared to arterial occlusions. And then once we have crossed the lesion, then IVAS is done for the common femoral vein, external iliac vein, common iliac vein, and IVC to identify lesions in appropriate landing zone, proximal and distally. The degree of stenosis is best calculated using the expected normal area for the location. So there are means we can compare the normal area or the diameter of the contralateral normal vein, and we can size the stent accordingly. Then pre-dilatation with large caliber balloons, so 16 to 18 mm high pressure balloons, and recoil is routine. That's why stent is always done in the iliac vein. So large caliber stents are approximating the normal size of the iliofemoral segments, usually for the PTS 16 and 14 mm used. If so sometimes more people, if they don't have the larger size stent, they use the undersized stent. So this is the means worst thing that you can offer to patient with iliac stent if you are putting in 10 mm stent or 12 mm stent, because you have now created an iatrogenic stenosis that cannot be treated with any of the endovascular treatment except for open surgery. So better to leave the patient till the proper size of stent is there. And most of the time patients are requiring 2 or 3 stents from the IVC or the common IVC confluence to the common femoral vein confluence. But we have to take care that there should be no overlap near the flexion area, near the groin. Overlap should be in the curvature of the pelvis. Dedicated versus non-dedicated venous, both can be used, but dedicated venous stents are especially designed for venous stents, so they have characteristics that they are stiff at the both the ends, so they are they are protective or from the compression of the common iliac artery and compression of the inguinal ligament, and in the pelvic region they are more flexible to follow the pelvic curve as compared to non-dedicated stents. Post dilatation is must, so always after placement the post dilatation and then check with the IVAS. The principle is to treat entire disease segment or lesion in continuity from the common iliac vein to the from normal vein to normal vein, and skipping short segments may lead to the recurrence and stent thrombosis. Most limbs with PTS require extension of stent below the inguinal ligament into common femoral vein just above opening of the profunda femoral vein. In arteries, we avoid crossing the joints, but in veins, there is no such concern, and they can be crossed easily with a wide range of literature available with no debate on this thing. Stent fracture and erosions are rare with stent crossing the joint crease. Proximal lesion at the iliocaval confluence is a spiral incomplete stent. So people, what we fear that if we cross the stent too much in the IVC, it might jail the contralateral limb, and that may cause the contralateral DVT. But with this fear, we place the stent distally, and then we miss the proximal lesion and leading to the recurrence of symptoms or thrombosis of the skin. So IVAS is used to cover to proximally to accurately localize the lesion and cover whole of the segment. And people usually leave the stent 3 to 5 centimeter above the confluence without any effect on only 1 to 2% reported rate of contralateral DVT without any gelling. So this can be prevented by using IVAS and extension of iliac stents a few centimeters into the IVC. The stent may be used proximally, we can see. IVAS to confirm adequate stenosis correction and check venogram at the end of procedure. Recanalization of CTOs, surprisingly amenable to percutaneous recanalization even in the outpatient settings with success rate up to 85%. And blind threading of the glide wire through the trabeculated vein, then passage of the tip of the guide wire rather than the loop. In arteries, we sometimes use the loop to cross the CTOs, but in the venous occlusions, because there are micro openings and trabeculation, so loop doesn't follow well, and the tip of the glide wire follows well, and along with the angle tip guiding catheter. Free hemorrhage is very rare. So if we are doing the angioplasty in initial days, people used to dilate the iliovenous occlusions with 5 mm, 6 mm, 8 mm, 10 mm. Now it is routine that directly dilate with the 14 or 16 mm balloon and put in the stent direct.
Yeah, these are very good technical points you are mentioning, and they're very relevant. We'll
So-
take about 5 minutes for the discussion, and maybe we can go to the next, and we will definitely listen to this wonderful presentation, maybe a separate time. That was very good
Okay.
points you have raised. And
Okay.
Let him complete.
Yeah.
Let him complete.
Yeah, Dr. Iram is waiting actually.
No. Let him complete.
चले ठीक है फिर डॉक्टर इरम ये होगा कि हम आपकी प्रेजेंटेशन नेक्स्ट टाइम कर लेंगे
नहीं मैं अपनी
सर, मैं सर
कंप्लीट
खत्म
जल्दी
कर
कर
देता हूँ।
लूंगी। आप कंप्लीट कर ले, मैं अपनी
हाँ
कंप्लीट
ठीक
जल्दी कर
थैंक
लूंगी।
का मैं खत्म कर दूँ तो passage of wire in the other important aspect is passage of wire into vertebral one. Sometimes it goes into the we are following the wire in the means AP projections. So sometimes it goes into the vertebral veins and the wire is going straight forward in AP view. So it is always mandatory to check the once we have crossed the lesion to check with the lateral views whether it is ventral to the vertebral canal or it is posterior to the vertebral canal. And once crossed, then IVAS pre-dilatation, stenting and post-dilatation, check venogram and final, check IVAS and final venogram. Anticoagulation, so routine anticoagulation with ACT of around 250 during the procedure and post-procedure low molecular weight heparin during the hospitalization and post-hospitalization DOACs. In patients with PTS, if there is a provoked DVT and resolved risk factors, then SAPT after 3 to 6 months and anticoagulation for 6 months. Long-term anticoagulation, if there is a unprovoked DVT, thrombophilia, recurrent thrombosis, or extensive stenting, or there is an issue in the stent, like in stent restenosis. So this is the stent. Before placing the stent, there was occlusion with collaterals, and once we have placed the stent, there is no collaterals. This is the picture showing the okay. So this is the picture which is showing the that the stent of undersized stent placement. So you can see that even the common femoral vein is larger than this one. So this is the iatrogenic stenosis now for whole of the time that cannot be corrected endovascularly. This is the importance of IVAS, but we can discuss in some other times. Stent surveillance, so usually needs for the PTS patients needs at least the quarterly surveillance during the first year and at least every 6 monthly thereafter, along with anticoagulation. And so outcomes, patency rates are good for the patients with the only for compression syndromes. And they are better for the patients in patients who are having the PTS with primary patency rate up to 60%, but secondary patency rates reaching up to 90%. So these were some different scenarios, but I think we don't have time to discuss this. I think this is all about my presentation.
This is wonderful.
Or we can discuss these ones.
Yeah, maybe, yeah, William, this is very important. Yeah, different scenarios. If you discuss before I go, I will ask the audience if they have any question. I will say, William, this was an excellent presentation. And every slide has wealth of information, which is very relevant. And we will request you to give a full lecture on this. Probably this is a short review type session, therefore. So can you go through different scenarios? That will be very interesting for the trainees. Yeah. Yeah.
So means the patients with PTS or venous disease can present with multiple issues at a time. So if a patient who is having superficial reflux in great saphenous vein, we have done the scan and there is superficial reflux in GSV, along with we have seen on the ultrasound scan or their patient has broad CTV or MRV that is showing that there is common iliac vein stenosis or compression of more than means 50 to 70%. Now, what should be the algorithm and how this patient should be treated?
So,
We have talked, I think, some things in the presentation. So anyone can.
we should first go for the superficial reflux, and then if the condition is not improving, then go for the iliac stenosis or compression.
Anyone any other opinion?
Sir, I'm Kamran. For my choice is first go for the deep venous issue. First, I will offer the patient if the facility is available. If the symptom persists, and then I will go for the superficial.
Any other? So we discussed already the algorithm of offering intervention. So we have multitude of problems and multitude of options. So that depends on the severity of the lesions means there is stenosis or occlusion and how much reflux is there. The other thing is how invasive is the procedure. And third thing is where the stenosis or occlusion is located. So here we have superficial reflux and compression. So superficial is always treated first in these cases because the ultrasound or CT or MRV is done. We don't know about its significance. Significance of the iliac lesion, whether it is means even significant or not. And the other thing, the other important thing is it is more invasive. Patient has to be on DAPT, patient has to need anticoagulation, and the longevity of, although there are reports of 10-year patency rates, but most of the patients, these patients are venous disease patients are younger patients. So we don't offer them more invasive. First, we treat the superficial reflux and observe for the symptom improvement. If there is no symptom improvement, then we can offer them for the iliac vein lesions. Okay. Then the same patient, there is superficial reflux with iliac vein occlusion. Now, Shafila.
Deep vein first.
Then we will go for both procedures simultaneously if possible, or we will correct the occlusion and then we'll go for a superficial reflex, because we already know that there is a pathology inside the abdomen, and if we correct the reflux, so the occlusion will always be present there.
Yeah, so the means most of the people are in a agreement that the iliac vein occlusions are more hemodynamically significant as compared to the superficial reflux, but also depend on the extent of superficial reflux, whether it is more than 0.5 seconds or it is more than 3 or 4 seconds. So if there is massive reflux, then it can be staged as a superficial reflux followed by the iliac vein stenting. But still, this patient will need the iliac stenting. So any patient with iliac occlusion, if most of the time they need the iliac stenting, and the treatment of the superficial reflux in the same setting or state setting few weeks back, because patients are anticoagulated and with ACT more than 300, 400, most of the time they give a lot of heparin in complex iliac occlusion. So in those patients, the treatment of the iliac vein lesions first, followed by the treatment of superficial reflux if needed within a few weeks. And depending on how significant is the reflux, you have treated the iliac vein occlusion and reflux was only more than 0.5 second, may not need treatment, but we have treated iliac occlusion and the reflux is also significant, more than 2 seconds, 3 seconds, then it also needs to be stayed within few weeks. Coming to the superficial, so now the patient has come, we have done the scan, we have done the cross-sectional imaging, so there is iliac vein occlusion, there is deep reflux. So one important thing is deep reflux. If any of the ultrasound reports a deep vein reflux, then always it is as a rule that most of the time it is due to DVT unless proven otherwise. So deep vein usually don't have the reflux. So if there is reflux, then we must always reconsider the DVT. So if there is superficial reflux, deep reflux, and iliac vein occlusion, then what should be the algorithm? Then algorithm for, means is the same. We have to treat the iliac vein occlusion. Most of the time, if the occlusions are resolved, the reflux has no significant impact in the wound healing rate. So there are many papers on this. The patients who are having occlusion and reflux. So most of the time, the patients who are treating with iliac vein stenting, they don't really need any further intervention for the reflux. Only small number of patients who need then the intervention for deep reflux. And same goes for the superficial. So superficial depends on how severe is the superficial reflux. If it is just reaching to the significance 0.5 second, 0.6 second, less than 1 second, then it might not need any treatment. And if it is severe enough, then it might need the stage treatment after the iliac vein treatment. Now the patient has came to us. So patient has history of DVT. He has brought ultrasound. So there is no proper inflow. So anyone can tell just what is no proper inflow? What is the proper inflow?
proper inflow when there is flow in the common femoral and deep femoral vein.
No, common femoral
Then
vein.
femoral and profunda
Yeah.
both are the patent. This is a proper inflow.
This is the excellent inflow. But if any
But
one of
one
them
of the yes, sir.
them is patent, then still we consider it is a proper inflow. But if both are not, means both are involved in the post-thrombotic syndrome, both are not very well recanalized, then it is called as no proper inflow. And this
So
patient,
this is not a patient for the intervention. Good patient
yeah,
for the intervention.
yeah. So we can't offer anything for iliac stenting. So no iliac intervention, no superficial reflux to offer in this patient. Now this patient is having venous ulcer. So then
So
these patients,
we will
Mhm.
start with the conservative treatment first. We will
obviously
do
conservative treatment is for every patient, whether we are going to offer intervention or not. So most of the time these patients are already on the conservative treatment. Then we have to just, if the patient is have ulcer, then we have the option of sub ulcer plexus sclerotherapy. So if there is no inflow, there is no reflux, then we can think of the injecting sclerotherapy in the base of the varicose in the base of ulcer, and the ulcers respond usually well with this treatment, and there are many case reports and series on this. Then there is an other scenario that there are varicose veins with the superficial reflux from the pelvic origin, and deep veins are normal. So in the leg, deep veins are normal, but in the pelvis, we don't have any imaging yet. The patient has come, so lady with 36-year lady with varices on the upper medial thigh, posterior thigh, and we have done a scan. So this is non-saphenous reflux. Saphenous veins are normal, but the varicose vein are coming from the pelvis. The vulvar varices are there. So now, what to do this with this patient?
in these patients, we first have to ask of the history. If these patients have pelvic symptoms, then we will go for the pelvic veins embolization. If they don't have any pelvic symptoms, then we treat the varicosities with the foam sclerotherapy. And at the junction points where they are entering into the thigh, exact word I have forgotten.
Entry points. Exit
Entry points and exit points. We have to do foam sclerotherapy at that very points.
Any other comments?
We have to rule out the nutcracker syndrome, I think, in these patients.
So, means these varices of pelvic origin, they are means categorized into primary and secondary. Secondary may be due to the compression syndrome. Compression syndrome may be the iliac vein compression, or the compression may be from the left renal vein compression, leading to the reflux in the gonadal veins, and from gonadal veins into pelvis, and from pelvis downwards. So we have to look first to exclude the compression, this thing. But so there are two approaches. One is top to bottom and bottom to top. Top to bottom means, do we have treat the lesion in the, if there is compression syndrome, then treat the LRV compression or the left iliac vein compression, and embolize the internal iliac vein or the gonadal vein. And then the bottom means then to address the leg symptoms. Bottom to top is just like Shafula said. So foam sclerotherapy or the step evaluance of the leg varices, and then if not means resolving, of if recurring, then go to the pelvis. So these are two approaches: bottom to top, top to bottom. So the clear cut indication is bottom to top. Whatever the pelvic pathology, if there is primary or secondary, if patient doesn't have PCS, pelvic congestion syndrome, then we have to do top, bottom to top. We have to just treat the leg veins, and 95% of the time there is no recurrence. But if there is the patient who is having recurrent varicose veins with bottom to top approach, or the patient is having pelvic congestion syndrome, then we have to address the pelvic issues. Then we might need to treat the left iliac vein compression, left renal vein compression, or embolization of the internal iliac or gonadal veins. So, and sometimes, so we see many times the patients who don't have any identified superficial reflux we don't see any major reflux, but there is lipodermatosclerosis things and non-healing ulcers. So we have to look for other causes like vasculitis in these patients. This was, I think, all about. These are many things, but we leave to the patient.
Excellent, excellent. And that was super. You actually mixed with different scenarios, and these are practical issues which they face. And there are very relevant points in the exam which you have mentioned. And these are practical things, but there's a lot to talk and a lot to learn from you. And thank you for your precious time and bringing your experience and sharing with us. We will definitely arrange some Venus session, especially the deep one. And that is an interesting area to look and work upon. Thank you, Waryam. And before next, I say that we have Dr. Idam with us. Dr. Idam is working as a consultant vascular surgeon in SIUT. Dr. Idam, आपके पास है? I make you co-host, actually.
So I have to share my
Yeah.
presentation.
मैं आपको co-host बनाता हूँ 1 मिनट. You